Good afternoon, morning, depending on where you are.
Okay. Okay.
If I could ask everyone to put,
Okay.
please.
Okay.
Thank you. Welcome, everyone, and thank you for coming today.
Okay. All right. Well, thank you for your help. I appreciate it. Okay. Have a great day. Bye.
So I would like to ask people to go on mute.
I know.
So welcome, everyone, and good afternoon or good morning, depending on where you are. Welcome to the inaugural webinar of the International Networking Group, Innovations in Rehabilitation from Around the Globe. My name is Fofi Constantinidou, and I'm the chair of the International Networking Group of ACRM. Our speaker today is Professor Barbara Wilson, speaking on the neuropsychological consequences of COVID-19. We're very excited about today's presentation and, of course, having Professor Wilson with us. Before we get started with the presentation, I do want to advise that this meeting is being recorded. I would like to ask all attendees to keep your phones or mics muted and to keep your cameras turned off throughout the presentation. We do expect to have about 20 minutes available for discussion at the end of the webinar. So if you have questions, please type them in the chat and we will do our best to address as many of those as possible during the latter part of the hour. Now I would like to pass the slides to you, Professor Wilson, and I will, while you're doing that, I will introduce you. Professor Barbara Wilson is a clinical neuropsychologist who has worked in brain injury rehabilitation for 43 years. She has published 32 books, 204 peer-reviewed papers, 124 chapters, and 8 neuropsychological tests. I know she doesn't need introductions in the field of clinical neuropsychology, but I will try to provide a few highlights from her very important career and contributions. Barbara has won many awards for her work, including the Order of the British Empire from the Queen of England in 1998 for services to rehabilitation, and 5 Lifetime Achievement Awards. She also received the Raymond Waikahal Award from the International Neuropsychiatric Association, and also has received an honorary degree from the University of Cordoba, Argentina. She received the M.B. Shapiro Award from the Division of Clinical Psychology in 2014. In 2019, she received the annual award from the Spanish Clinical Neuropsychological Society. She's editor of the journal Neuropsychological Rehabilitation, which she founded in 1991. In 1996, she established the Oliver Zanquil Center for Neuropsychological Rehabilitation. She's president emeritus of the UK Encephalitis Division of Neuropsychology. The UK Division of Neuropsychology has named a prize after her, the Barbara A. Wilson Prize for Distinguished Contributions to Neuropsychology. She's also fellow of the British Psychological Society. She has held 30 research grants. Her work has influenced clinical practice. For example, as a result of the randomized control trial on evaluating a paging system to improve memory deficits, the local health authority has set up a healthcare system using the paging system throughout the United Kingdom. She's currently working freelance at St. George's Hospital in London on the neuropsychological consequences of COVID-19, and also she consults for the Oliver Zanquil Center. So Barbara, the floor is yours. You're muted, Barbara, so let's make sure we unmute you.
Sorry.
Yeah.
Okay, well, as I was saying, thank you very much, Fofi. Can you hear me all right now?
Yes.
And hello, everyone. I'm very happy to be here today. So this talk, The Neuropsychological Consequences of COVID-19, is done with help from Jessica Fish, who's there, Abigail Nancaro, who's there, and Shay Bettridge, who's there. This is Shay and me in Granada about 2 years ago. Now, this is a very rapidly changing field, and I'm sure that lots of you listening will know as much about this area as I do, but anyway, here goes. So first of all, no conflict of interest. This is me completing the London Marathon in 2008, one of my main goals in life, but right, now how did I get started in COVID-19 and the interest? Well, I listened to a webinar by Elkanon Goldberg, who's originally from Russia, but now lives in New York. And that's how I first became interested in it. He did this excellent webinar in May 2020. He did another one in July 2020, and he's done several others since. And I got really excited by what he was saying. So I'm indebted to Elkanon for some of the background information presented here. So neuropsychology and COVID-19 then. Well, I think we know now a considerable amount about the medical aspects of this new coronavirus, SARS-CoV-2, and the illness it causes, namely COVID-19. But less, I would suggest, is known about the neuropsychological aspects. And many COVID-19 survivors who've been seriously ill are likely to need ongoing help. We know that many organs can be affected by the virus, including the lungs, the heart, the blood, the digestive system, and central nervous system involvement has also been documented. So in some cases, the virus can directly affect the brain with both infection and inflammation-based mechanisms possible, and a range of secondary neurological effects as part of the broader systemic illness have been reported. So the brain can get attacked either directly or as a secondary consequence. So COVID-19 then is associated with cognitive and emotional difficulties, in addition to the persisting physical symptoms in a proportion of survivors. And this is likely to occur, not only with these, but more likely to occur with the highest frequency and severity in people with overt neurological illness associated with COVID-19. But patients without overt neurological involvement may also experience cognitive and emotional difficulties, alongside difficulties with breathlessness, fatigue, and deconditioning. Now, in Britain, there's this big study called the Corona Nerve Study, and all cases of those with COVID-19 admitted to hospital and presenting with neurological and neuropsychiatric features have been carefully profiled as part of the Corona Nerve National Registry Study. The paper was published last year with the first author, Varat Haraj. But this study and others have indicated that strokes, encephalitis, and hypoxia, I know the Americans say encephalitis, but the Brits say encephalitis, and hypoxia may occur after COVID-19, and many people with these conditions may require referral to a neuropsychologist. Now, we are told that the frontal and temporal lobes are the most likely to be affected. But anecdotally, when those of us working in this field get together by Zoom and talk, a number of us have seen more posterior damage. So I don't really know how true that is, that the frontal and temporal lobes are most likely to be infected. It seems to me that anywhere in the brain can be affected. But the hippocampus does seem to be particularly vulnerable to the coronavirus, Liu et al. 2020. And of course, if that happens, that's likely to lead to an increased risk of memory problems and a possible acceleration of pre-existing neurodegenerative disorders such as Alzheimer's disease. So we may be seeing a bigger percentage of people with Alzheimer's than we're used to over the next decade or so. I think we've got to watch out for that. Now, another important study in the UK was done by Adam Hampshire, who's here, and his colleagues, published last year. And with specific reference to COVID-19, a recent paper by Hampshire et al. 2020 analysed the cognitive aspects of 84,285 participants in the Great British Intelligence Study. And they additionally completed an online survey regarding suspected and confirmed COVID-19. And they found that people who'd recovered from COVID-19 had more cognitive deficits relative to controls, even when they accounted for a wide range of demographic variables. And taken together, these findings strongly suggest that cognitive deficits are likely to be common in people who've had severe forms of COVID-19, even when they haven't had a neurological presentation in the acute stage. So some of them do, they have a stroke, for example, but some don't, but they still have these additional cognitive deficits. But it follows from the wide variety of neurological and neuropsychiatric profiles reported that the cognitive profiles are going to be diverse. Now, this is Jwala Narayanan, an Indian colleague of mine, and I'll say a bit about her patient in a minute. But as neuropsychologists, we must be aware of the possibility that rare and/or difficult to diagnose syndromes may result. So this Indian colleague, Jwala Narayanan, she had a 62-year-old patient who developed COVID-19, then had a stroke, and then was left with Balint syndrome. Now, Jwala emailed me about this when she first saw this woman, and I got really excited and said, we have to write her up. So Jwala, Jonathan Evans in Glasgow, and myself wrote a brief paper which is published in the Journal of the International Neuropsychological Society's newsletter. And as far as we're aware, this was, I say is, but it was, because there's been others now, the first patient with this syndrome, with Balint syndrome, to be reported in a patient with COVID-19. But I now know there are at least 2 others with this syndrome that have been reported. And some of you will never have heard of or seen anybody with Balint syndrome. It is very rare, but it was named after a Hungarian neurologist, Rezo Balint, who's here, who in 1909 described a syndrome comprised of 3 components. First, psychic paralysis of gaze or optic apraxia, and that's an inability to look voluntarily into the peripheral field. So they can't look where you ask them to look, for example. If you're doing a computer test and you say fixate on the cross in the middle, they can't do it because they can't fixate on that cross. So that's the first symptom. The second one is optic ataxia, which is an inability to look voluntarily into space or manually point to visually presented objects. And usually I find clinically, this is the first sign you see. You say, touch the pen, for example, and they miss it. They go to the side or the front or the back. They cannot localize in space. So they can't sit on a chair accurately, or they may be in a wheelchair and sit at a very odd angle. But it's this inability to point to things that I find clinically is the first trigger that makes me think, aha, I better look further into this. But the third component, remember Balint said there were 3, is simultanagnosia, where despite adequate visual acuity, if you give them even tiny single objects, a single letter, they can read it. But if you put 2 objects or 2 letters or 2 words side by side, they cannot deal with more than one of them. So it's not that they can't see, but they have this simultanagnosia. So if you're going to say somebody has Balint syndrome or Balint syndrome, as we tend to call it in the UK, they've got to have these three components. What about the anatomy with Balint syndrome? Well, it's associated with bilateral parietal lobe damage or parietal occipital damage. Now, this is not our patient, not the Indian patient. This is another one, but you can see the damage there. And this, I think that's a bit difficult for you to see if the slides are, but this is the Indian patient. And she has got bilateral occipital, bilateral parietal occipital damage. So this is the woman we wrote up. She was a 62-year-old right-handed female. She developed Balint syndrome following an ischemic stroke. If they have a stroke after COVID, it's typically an ischemic stroke, and more people in the general population have that anyway. And then she had acute respiratory distress syndrome, or ARDS, and sepsis. So she was very ill. But she was a well-educated woman. She had a master's degree and had been a teacher. And she came to the clinic to see Jawala in Bangalore in India one day, after she was stable and she was having physiotherapy or physical therapy. So, and she'd suffered an ischemic stroke in the bilateral parieto-occipital region. So the main messages from that particular case is that a rare syndrome might sometimes follow a stroke caused by COVID-19. And neuropsychologists should be aware of this when assessing patients with a diagnosis of COVID-19, as the syndrome's easy to miss and it's often mistaken for blindness. I think of the 4 or 5 people I've seen over 40 years, more than 40 years, nearly all of them are misdiagnosed as being blind, which is not true. They're not blind. And as more patients diagnosed with COVID-19 are likely to be referred for a neuropsychological assessment and treatment, and some of these will have had a stroke or hypoxic brain damage, we need to ensure that such rare syndromes are not overlooked. Most of the ones I've seen have had Balin's after and not severe anoxic damage, but this it can happen obviously after a stroke as well, as it did with the Indian patient. Now, a recent review, well, came out last year by Karen Ritchie, Ritchie, Chan and Watermeyer. Now, this is Karen Ritchie here. It sounds like a very English name, but she's French. But anyway, they published a paper looking at the broader neuropsychological aspects of COVID-19. And they cite a preliminary study documenting that 70% of people with COVID-19 admitted to intensive treatment units, so ICU or ITU, required mechanical ventilation. So 70% of those going to intensive care needed ventilation. And they link this to the literature on cognition on acute respiratory distress syndrome, ARDS. And they suggest that up to 78% of people with ARDS had cognitive problems a year post-discharge. Now here they're looking at the other SARS problems. You probably know there are 7 SARS illnesses, and 4 of them are relatively mild and 3 of them aren't. And the 3 that aren't, there's the original SARS, there's MERS, the Middle East Respiratory Syndrome, and there's the current SARS-2 or COVID-19. And looking at the other earlier SARS, another SARS, not our COVID-19, but SARS-1, approximately 50% of people had problems at 2 years post-diagnosis, and some of them self-reported everyday memory failures, such as forgetting medication and appointments, and they persisted in patients 5 years post-discharge. So some of these are long-lasting. And a proportion of those who've spent time in intensive care, and obviously that overlaps with the ARDS, they're known to experience lasting cognitive impairment. So Walters et al., 2013, this is the first SARS, the other SARS, found that in a systematic review of the literature, that although the estimated prevalence of cognitive impairment varied between 4 and 62%, huge variation, but that's because they were followed up at different times from 2 months to 156 months. So you're going to get high numbers, I would suggest, in the ones followed up at 2 months, and much lower numbers in those followed up 156 months. But the majority of studies have identified that critical illness and associated treatment is linked with lasting cognitive deficits. And together, these findings suggest that enduring cognitive deficits are likely to be common in people who've had severe forms of COVID-19, even without an obvious neurological presentation in the acute stage. Then, of course, we've got the emotional consequences. And in our St. George's lot, these seem to be more common than the cognitive ones. But regarding the emotional consequences of COVID-19, the Ritchie et al. Review cites research on psychological distress in MERS and SARS. They're the other two coronavirus problem situations. And they indicate 70% of people with confirmed MERS, the Middle East respiratory syndrome, showed psychiatric symptoms, including psychosis and hallucinations during their admission. And a study of 90 people with SARS showed 59% were diagnosed with a psychiatric disorder, which persisted in a third of cases 2 to 3 years after the illness. And family members and carers may also experience anxiety, stress, problems with mood and sleep. And these problems could well be exacerbated by restrictions on visiting family members in hospital. Been a big argument in the UK that family members have not, well, they are now, but they weren't for a long time allowed in, even when the people were dying. But now they're allowed in when people are dying. And a recent paper by Halpin et al. Looked at COVID-19 patients who've been discharged from hospital and found that fatigue, breathlessness, and psychological distress were the most common symptoms in this group. Now, I found this an interesting paper, so I'm going to go through some of the things they found. But as an audit of a London-based post-COVID follow-up service, not the St. George's one, which I'm going to come to in a minute, but another London-based hospital, indicated that around half of those hospitalised with COVID-19 report continued breathlessness at a 2-month follow-up, 2/3 reported fatigue, and 15% depression. And given the interplay between emotion and cognition and the difficulty of interpreting cognitive test results when significant emotional difficulties are present, you can't always tease out what's cognitive and what's an emotional problem, for example. But whatever, specialist clinical neuropsychology involvement and the clinical assessment of patients recovering from COVID-19 is crucial. Sorry, we don't want that. Now, this is a paper by Misra et al. Came out just this year, even more recent, and they looked at papers from 55 countries in all, but they didn't report on ethnicity, which we've found, along with others, is an important factor. More of that later. Anyway, apart from the ethnicity one, they showed 89% of cases were hospitalised, 6% were not hospitalised, and 5% the hospitalisation wasn't reported. There were 41 neurological manifestations with 24 symptoms and 17 diagnoses. 54% of the cases in those 55 countries studied were male. Now, we found even more males than that. We found 2 to 1 or more than 2 to 1. 32% had fatigue, 20% had myalgia, 21% had taste impairment, 19% had smell impairment, 13% had a headache, 31% had myalgia or fatigue. They seem to have confused some of those earlier things. 7% had dizziness, 12% had headache and dizziness together, 18% had smell or taste problems, 11% acute confusion and delirium, 7% disturbance of consciousness, and 45% agitation, and 24% had neuropsychiatric problems, plus 5% skeletal muscle injury, which wouldn't, I suggest, come to a neuropsychologist. But up to a third of the COVID-19 patients, up to a third, experienced at least one neurological manifestation. Disturbance of consciousness and fatigue was associated with the severe cases, and no other problems were particularly associated with severity, just this disturbance of consciousness and fatigue. And the mild cases were more likely to have problems with taste and smell. And that may be because they're more likely to report it. If you're really seriously ill with something else or a disturbance of consciousness, you're not going to complain about smell and taste problems. And 20 studies looked at young patients, that's under the age of 18 years. And 14 of these studies looked at elderly people, that's over 60 years. And the over 60-year-olds, of those, 34% had acute confusion or delirium, and that was associated with an increased likelihood of mortality, which isn't surprising because they're older anyway. Now, what about the pre-existing medical comorbidities? We found most of ours at St. George's have this. Well, of this is the Misra et al. Paper still. 26% had hypertension, 14% had diabetes, 10% had cardiovascular or cerebrovascular disorder, 5% had chronic obstructive pulmonary disease, COPD, 5% had chronic kidney disease. When I first saw those in the St. George's patients, I think that surprised me more than anything, that they were needing a dialysis for kidney problems. I somehow wasn't expecting to see that. 4% had a CVA. And I must say, there's lots of differing figures on how many get CVA, but in this particular study, they found 4%. 4% had malignancy, tumour of kind, and 4% had chronic liver disease. Now, the most common neurological diagnosis was stroke. And overall, it's 2%, so 1 in 50 seem to get a stroke. And ischemic stroke or transient ischemic stroke, attack, TIA, only 1%. Hemorrhagic stroke, just less than 0.5%. And cerebral venous thrombosis, only 0.12%. Right, so of the non-hospitalized cases, they found 50% had problem with smell, 44 problems with taste, 31 with headache, 31% with myalgia, and of the hospitalized cases, 31% fatigue, 30% myalgia and fatigue, and the mortality, well, if you had a neurological manifestation and you were over 60, then 27% of them died. And brain involvement was more common in those 60 plus years. And delirium seemed to be an independent factor, risk factor of dementia and mortality. But there were limitations to that study. It was retrospective rather than prospective. They didn't look at the timing of the symptoms. When did these come in? How long did they last? They didn't look at whether people with, say, Parkinson's disease or multiple sclerosis or myasthenia gravis got worse over time. Something we found in the St. George's lot, by the way, that if they had Alzheimer's disease to start with and then got COVID, then they went downhill quickly. And little data from low-income countries and no data, as I said earlier, on ethnicity. And then we get long COVID. Now, it's a broad term used to describe a range of presentations in the post-acute phase, ranging from those with identified serious medical complications to those with prolonged non-specific symptoms after relatively more mild illness. So it's a very broad term, and it seems to affect about 10% of patients in general. And a number of studies come up with this 10%. And these presentations can include cognitive symptoms along with physical and emotional ones. And these people would also likely to benefit from neuropsychological assessment and rehabilitation. Now, I'm going on to the St. George's one quickly, because I know I've got to finish in about 5 minutes, I think. But we did this audit because we know that the neuropsychological consequences of COVID-19 are likely, but we didn't know the type of problems being referred to clinical neuropsychology services. We didn't know how many people were affected or how long the problems last. And we still don't know how long the problems last. We've just started the follow-up study, which we haven't got data on that yet. So to begin to build a basis for understanding the neuropsychological needs of this population, we carried out an audit of COVID-19 referrals to our service. And we also included referrals to the general post-COVID pathway and to the specialist vocational rehab pathway. And we look at those separately as well as together, because although lots of places have a general post-COVID pathway, very few, at least in the UK, have a vocational rehab pathway. Anyway, so let me, then I just want to mention this Public Health England report that came out last year showed that people from Black, Asian and minority ethnic backgrounds, so the term used for those is BAME, and that is politically correct in the UK, the BAME group are up to twice as likely to die from COVID-19 as people from white British backgrounds. And they're also more likely to get referred to neuropsychology. So we decided we'd look at ethnicity as well. And this report, this was from March to December last year, 66 people were referred to the post-COVID neuropsychological assessment service between March and December 2020 for assessment in relation to cognitive and or emotional consequences of COVID-19 and treatment as well. Some of them are having treatment. So they took referrals from the large inpatient wards of the large teaching hospital in St. George's in southwest London and from district hospitals in the wider region. And the patients ranged in age from 31, that was the youngest, a young Arab girl in our case, to 84. We had several 84-year-olds, with the mean age being 56 years and a standard deviation of 13 years. And the men outnumbered women by just over 2 to 1. The majority, 65%, were for people with possible cognitive and or emotional difficulties resulting from severe COVID-19 without any overt neurological event. They hadn't had a stroke or encephalitis or Guillain-Barré syndrome or any of those things. But we did have some referrals for those with a pre-existing neurological condition, such as Alzheimer's disease, and the COVID had led to a decline in function, 18% of those. And then there were those who had been well, got COVID, and then got something. And most of those were stroke patients. There was only 6% in total, with stroke patients being the commonest. And we also had some people with persisting cognitive and or emotional symptoms in the context of milder initial illness. So the illness was milder to begin with, but they did have problems. And we found more patients from ethnic minority groups than the census data indicate reside in the hospital's catchment area. So St. George's Hospital in London is in a very ethnically diverse area anyway, but it was even more than that, getting referred to neuropsychology. Now we found referrals to the vocational service were younger on average than those that went into the ordinary COVID-19 pathway, but otherwise they were demographically similar. So let me just take you through this St. George's data briefly. I know it's a busy slide, I'll talk you through it. So this was the group who had been well, got COVID and got admitted to hospital. 20 in the standard group, 23 in the vocational group, 43 altogether, 65% of the sample. This was the group that had been okay, got COVID, and then got a neurological problem, typically a stroke. So we've got 3 in the standard group, 1 in the vocational group, 4 altogether, and that was 6% of the sample. These who'd had something wrong before, like Alzheimer's or Parkinson's or whatever, sickle-cell disease, HIV, there were 12 of those in the standard group, none in the vocational group, because they were less likely to need to go back to work, 12 altogether. And those who had a pre-existing non-neurological, so anxiety, depression, something, or diabetes or asthma, there were only 2 of those in the standard group, and the non-hospitalized long COVID, 3 of those, just about 7.5% of the sample. Now, the male, I'm going to stop very soon here because I think I'm running out of time, but altogether there were 43 males to 19 females. We are seeing more men. Now, we looked at an Italian study that we're presenting in Australia next month, and the Italians have much more equal gender balance than the Brits. I don't know why that is. Some weren't stated, whether they were male or female. I don't know whether these were transgender or they just hadn't been stated. Now, white, if you look at the total, 29 white, 17 black, 12 Asian, that's 29 altogether there, and not stated 8. The other would be some of the Arab people went into other because they weren't black and they weren't Asian particularly. But you can see that we shouldn't be having as many as that. And then the age, well, the total sample 56 years just over, 13 standard deviation in the range. I told you about that earlier. So the data reported here indicate that neuropsychology and rehabilitation services are much needed as part of the post-COVID healthcare landscape. And such services must be planned to be accessible for people of all ages and cultures and administered by staff skilled in working with complex biopsychosocial presentations. Sorry, if you're interested in the first bit of that, we did an editorial, which I can send to FOFI for general distribution for anybody that wants it, or you can email me. Now, I'm not going to talk about this. This is a British paper. The thing mostly about the paper from the British Society of Rehab Medicine was that it didn't really recognise the contribution of clinical neuropsychologists. Everybody got referred to a physio, and of course the physios are important. These people are deconditioned, but the physios don't know anything about cognitive problems, or they don't know as much as the clinical neuropsychologists. We do need to follow up. Those with ARDS have a high prevalence of cognitive impairment, often persisting for months, and probably about 10% are going to have long COVID. Now, I just wanted to end, this is one of my favorite quotes: "Compassion is the basis of morality." And that was said by Arthur Schopenhauer in 1840. And this is another quote I like by Nye Bevin, my childhood hero: "Illness is neither an indulgence for which people should have to pay, nor an offence for which they should be penalised, but a misfortune, the cost of which should be shared by the community." So with that, thank you very much for your attention. Thank you.
Thank you so much. Always very, very inspiring. We have more than 100 people attending this webinar, so it's a testimony to people's desire to learn more about the neuropsychological consequences of COVID, and also to listen to you, Barbara. So in terms of questions and comments, some of the things that were mentioned in the chat, and I would like to encourage everyone to please type questions and comments for our speaker in the chat. One of the things that came up as you were discussing, presenting your data, Barbara, were the types of treatment, the types of neuropsychological treatment or neurocognitive treatment that you find that is useful with patients having neuropsychological deficits with COVID.
Yes. Well, Abigail Nancaro is doing a lot of the rehab work at St. George's, and she's found that she's having to deal a lot with the emotional problems. So cognitive behavior therapy, group therapy, and the offshoots of CBT, like commitment therapy and compassion focused therapy. So those for a lot of the emotional problems are being dealt with. Some clinical psychologists, both at St. George's and in other places, are working with the families who've experienced a lot of stress. The ones with the severe cognitive problems, I think they're probably found more in the vocational rehab group. The younger people who are trying to get back to work seem to be needing those more. And I think my sort of general memory assessment, memory rehab programs and the cognitive rehab programs in general would be appropriate for some of those people. But Abigail Nancaro was telling me that the group therapy is very important for these people. I think they like to know they're not alone, they learn from others. And the one thing Abigail said that stuck in my mind, she said, if you see them early on, they tend to do better than if they get referred when they're a year or so down the line or several months down the line. But I think these are empirical questions that we have to look at more carefully.
Okay, thank you. One of the questions from Angela Colantonio, she's asking if any of the patients in the service, in your service, receive occupational therapy, which includes addressing cognitive challenges.
Absolutely, yeah. I mean, I'm all for working with OTs, and I work very closely with OTs generally. I always see them as the practical problem solvers. I think they're not all of them, but they're less good at writing up or systematically evaluating something, but they're good at solving problems. So, and I know in many countries, including the UK, there's far more OTs than there are psychologists, and we have to work together and use them. So I'm all for that. And they certainly get a lot of OT at St. George's too. And Shay Bettridge, who's the head of department there, she works very closely with OTs, and they've written, her and an OT have written a wonderful chapter about empowering patients through working together. So yeah, I'm all in favor of that.
Okay. Another question is, what are your thoughts about neuropsychological sequelae in people with mild cases of COVID-19?
Well, we are seeing it. It's less likely, but they do come along. And I think, well, it's probably, I think this 10% with the long COVID is probably the figure to hang on to. But I don't know that there's enough research out there yet looking at that group in particular. I mean, other people watching this may know far more than me about the long COVID, but they are getting referred and they are getting treatment. But the ones we've tended to focus on so far in the St. George's group are those who've been sent to intensive treatment units and have ventilation. I think they're the ones most at risk, but about 10% of them are going to have other neuropsychological problems too. So we've got to be prepared for all of this. The trouble is we can't get the funding for it. You know, if you're doing imaging studies, you get all the money, you get all the status, you get all the kudos. But if you're doing all the hands-on hard work for month after month after month, it's ever so difficult to get the money. And that's true in the UK, and I know it's true in America, and in some countries like I know India quite well. I mean, only a tiny percentage of people there get treatment from a professional. They're strong on families, so you have to use the families quite a bit. And that's true in Botswana and as well. And then the families might get burned out. So we have to watch all those things together.
So another question is, I guess it relates to the previous question about whether you feel that it's the respiratory distress that's causing the cognitive problems more than a neurological effect.
Yes, well, I mean, it's an interesting idea because originally it was thought to be a respiratory disease, wasn't it? It affected the lungs, and that was the primary source of the problem. But I think some of Elkin Goldberg's work, the brain can get attacked directly. So it's not just, and without the lungs being affected, sometimes it goes straight to the brain, or it can go to the brain through secondary causes. So I don't think it's just a respiratory thing. I think a lot of it is the breathlessness, the fatigue maybe, but it's not just that. I think there's other things too, but this is where you might need a more medical person than me, Fofi. I'm definitely not a medical person.
You have to see the comments in the chat. Everybody's praising you for this talk and thanking you for taking the time to present to us. And there, colleagues are agreeing with you about the money that is thrown at neuroimaging in contrast to clinical treatment studies. So you have a fruitful audience here. This group.
I have spent my professional career fighting the system, fighting for a better deal for people with brain injury and their families. So I'm used to fights, and that's one of the fights I have to have about the images.
Well, and you have someone here says that Dr. Wilson Yehuda will be proud. So.
Oh, well, I know Yehuda died recently, and he was a friend of mine. So.
Yeah, Bonnie Marks.
I saw Angel Sanders' name up there too.
Yes.
And she did a very nice review of one of my books, so I think I like her a lot.
So I can unmute everyone if you want to say. Let me remove the security here so you can actually unmute yourself. So if you want to say anything directly to Professor Wilson, you can unmute your mics and speak. I do have a comment here while people are contemplating to unmute their mics from Joanna Wolfson. She says, she's thanking you and she's saying, for those reporting symptoms of long COVID other than severity of illness, are there any other known or suggested risk factors for prolonged symptoms such as demographics, psychological histories, social network, etc.?
Yeah, well, that's an interesting idea. I mean, I think we just have to, again, it's an empirical question. We have to find that out. I don't know that we know that yet, unless other people do. But I think it might become clearer when we do the follow-up studies about whether there are. I know some of the people in Abigail Nancaro's group have had previous anxiety and depression, and that might be a risk factor. I don't know. We just don't know. We've got to do the research, I think.
Now, question for the follow-up studies that you mentioned. In your experience working with patients with longer lasting symptoms of COVID, when would you say would be appropriate to follow up people? Is it at 3 months, 6 months, in 1 year? What is your clinical gut feeling or based on experience?
Well, I probably like to do it every 6 months for a while, but in practice, we're probably going to be longer than that, because first you have to sort out whether you need ethics or not. Then you have to sort out who's going to be paid to do the interviews. Then you have to sort out, are we going to do a telephone interview? Are we going to do a Zoom interview? Are we going to do face-to-face? Can we get the assistant psychologist trained up to do this? And that's what we're sorting out at the moment. So we haven't actually started to do it yet, but we're nearly there, I think. And we're like, so I think it's going to probably be, in our case, 12-month follow-up to start with. But my gut feeling is we should do it at 6 months in an ideal world.
Okay. And then when you refer people to vocational rehabilitation, I mean, are you seeing the success rate that's similar to, let's say, mild TBI success rate, or, I mean, are you seeing different patterns of
I don't know. Again, it's an interesting question, and I think I'd have to go back to the people at St. George's Shay might know that. I have regular Zoom meetings with Shay and with Jessica about these things. But I mean, the ones that are getting referred are the ones that are still working, they're working age, that's why they're younger. They want to go back to work and they're having problems. And one of the people referred was a neuropsychologist. She got, I thought that was an interesting, I don't know, an interesting person to be referred. She wasn't working with the COVID world. She was doing research into Huntington's disease. And then she got COVID coincidentally, I think, not through work. And, but I don't know what the success rate is. I know what the success rate is for people with traumatic brain injury, for example. It's typically about 36%. But whether that's going to be higher than that or lower than that, and whether we've got enough people to do those kinds of studies yet, I don't know. You see, there's so many unanswered questions that we need to answer. And with all these people around the world listening, they may have the answers, or they may be doing it already.
Now, Angel Sander has a question. She says, do you think that it's similar to concussion in that if we can provide education about what to expect up front, it may reduce the downward spiral when they have symptoms?
Well, I think that's likely, Angel. And I suspect that's one of the things Abigail Nancaro is trying to do, because I'm doing everything remotely, you see. I'm not seeing these people. I'm just looking at the database to do the audit. But Abigail Nancaro is doing the actual hands-on work. So I think we should ask her that question. But it feels right. I'm looking at Angel's comment on here now. Similar, and I know that they are given information. So, but again,
I wonder if so like obviously not for the people who have strokes. I mean, that's sort of a different population, but for the people who have the milder symptoms like the fatigue and the concentration problems, like if you know, if people are told when they're diagnosed with COVID that these things might occur and like what to do if they do occur, if that might help with those cases.
Yeah. I think what I have to do, Angel, is put you in touch with Abigail Nancaro, because she could, I think she could probably answer that question better than me. All I know is it feels right. It feels that you're correct, but I don't know the answer. I don't know that we've got the data to tell us that yet.
Thank you.
So Angela, are you referring more to like a psychoeducational training? I mean, in the true sense of psychoeducation.
Yeah, or maybe even just a fact sheet, you know, something for them to have when, if they do start to experience those symptoms, they realize that it's because of COVID and not, you know, some other reason, and just reassure them of some steps that they can take, like use some strategies, or, you know, if they're feeling, you know, depressed, practice mindfulness or increase their activity. I mean, I'm just thinking about like tips like that we would provide to people with mild TBI, that might help them from not understanding what's going on and becoming more depressed and more inactive.
Yeah, I mean, I think, and that might fit in with what Abigail found about, she said that if you treat people early on, they tend to do better than if you wait for a bit. And it may be a similar sort of reason that they're getting more education early on about what to expect and where to go. I'm not sure.
Another question is, are there trends that you have noticed in the neuropsych data test with regard to specific neurocognitive domains impacted, or just overall heterogeneity?
Well, I mean, the things we're finding, they're reporting memory problems, they're reporting executive deficits, some are reporting fluency problems, and that's coming up on some of the tests we use. I mean, we don't use these big batteries like some Americans do, like Halstead Ritan or anything like that, but each area is assessed. And I know that the common, well, I think probably the commonest problem we're seeing for being referred is for mood. Mood and cognition are the two commonest. And of the cognition problems, it seems just executive symptoms, fluency, and milder memory problems. They're not severely amnesic, but they are coming up with, they're not so good on the memory tests. They're not so good on the executive ones. They're not so good on the fluency.
And Christine Kingsley has a question. If you have, if there is a test battery that you would recommend for moderate cases of COVID.
Well, everybody that comes through has the same battery in the St. George's lot. And I've got a list of that somewhere. I can't remember it off the top of my head. I've got a list somewhere which I can send to you, but it might be different in America or wherever this person's based. But my gut feeling here is it doesn't particularly matter what test. You've got to look at memory, planning, naming, executive function. You've got to look at all the cognitive domains. And I'm not sure that it matters too much. The advantage of everybody doing the same battery is comparison reasons, I suppose. But for clinical reasons, you just want to know, do they have problems in this area? Don't you? I'm sure I'm saying things that not everybody will agree with, Fofi, but that's typical of me too.
I don't know if you had a chance to look at the chat as we're talking, but there's so many people thanking you for doing this for us. What a great way to start our ING webinar series with your inspiring talk. And I want to remind everyone that today's presentation will be available on the website, on the ING website, probably on Tuesday. So you'll have a chance to be able to listen to the talk again and also share it with your colleagues and friends. And I really love the comment by Debbie Backus, ACRM's past president. She said, we're better to know you are in the world fighting the fight for those that need help, Professor Wilson. So with that, we would like to thank you. And we hope to have you with us again in the near future. Thank you so much.
Thank you, everyone. Bye. Bye.
So much.
Thanks.